So I want to emphasize first that I heard that I was introduced to lead a conversation, and I would like to encourage you to converse with me. So if there's anything I say that stimulates your interest and you'd like to discuss further, please go ahead and intervene. And if there's anything I say that you don't understand, please let me know. I'll be happy to go over it again. I hesitate to impose on your privacy, but how many of you have family members who have heart disease? Okay. And I presume that most of them are taking statin drugs. How many of you know what the statin drugs do? What do they do?
Well, they lower your LDL.
Yes.
Is that right?
Yes.
They might lower your triglycerides. They might raise your HDL. Maybe. I don't know.
Does anybody know how they work? Okay. So these are the risk factors that are well known to be implicated in heart disease. And what I'm going to spend most of my time talking about is the first two. That is the effects on LDL and VLDL and HDL.
Excuse me, in that case, why do so many doctors seem to emphasize total, the numbers for
Total cholesterol.
rather than LDL and HDL?
Right. So the reason that they do that is if you measure the total cholesterol, which includes both LDL and HDL, if you measure the total cholesterol and it's a low figure, then you don't really have to go any further to find out what's going on within those subsets of HDL and LDL. It's only if the cholesterol level is unusually high or unusually low that you want to find out which of these two components.
My total but my HDL is almost over 100.
Right, so that commonly happens with women, that women have high total cholesterol and high HDL. One of the things that we notice here is that it's not as good to be a male as it is to be a female with respect to this disease. And quite often, females tend to have high HDL. We'll come to it. Okay. So, what the response with respect to the treatment of heart disease has been quite helpful in the last couple of decades. And first of all, you notice that heart disease is the major killer for the American population, and that has significantly decreased in the last 2 decades. Cancer, on the other hand, the death from cancer has actually gone up. And most of these other things have stayed more or less the same. Chronic lung disease has gone up, diabetes has gone up, and that may be related to heart disease. There's another view of that same story, relating the outcome to particular interventions. This is one of the earlier drugs that was used to treat heart disease. The plumbers got busy on coronary arteries to try and open the diseased arteries up by putting balloons into the coronary arteries, stents into the coronary, and then the statins were introduced. And with the introduction of the statins, the death rate has continued to decline. Now, just so that you can understand something about how this process works, and please stop me if I say something you don't understand. This is a picture of a normal artery in cross-section, okay? And where all of the vast majority of heart disease encountered in clinical practice is ultimately attributable to the deposition of plaque in the arteries, okay? And the plaque is deposited in this layer, this very thin layer. Normal artery has a very thin layer lining the blood channel. And this thin layer is called the intima. Under normal circumstances, that intima is very thin and undiseased.
It's called what?
The intima, I-N-T-I-M-A.
As against endothelial.
And it has an endothelium lining it, correct. This is called the media, and this becomes implicated later, but not initially. So this is fundamentally an intimal disease, and the disease progresses as a result of the uptake of elevated LDL into the blood vessel wall. The blood vessel wall is infiltrated with elevated LDL, and that sits, for the most part, in this intima. And when it does that, it tends to attract cells from the blood into the intima. And it's those cells that ultimately sit in the blood vessel wall. You can see one of them over here. Those cells sit in the blood vessel wall. They take up the LDL. I'll tell you how in a moment. And they become swollen cells, which we call foam cells, because they are in fact foamy when you look at them under a microscope. We call them foam cells, and the foaminess is attributable to the accumulation of fat in those cells, derived originally from LDL. And as the disease progresses, this plaque in the intima gets larger and larger. It takes a long time for this to happen. They get larger and larger. And the real problem comes with respect to those of us who are unfortunate enough to have heart attacks is when the layer over the top of this plaque ruptures and it exposes itself to the blood flow. And then the blood platelets, which are the small cells that initiate blood clotting, okay, are activated when they see this break, and they form a blood clot over the top of this. And then you get a sudden blockage of the artery, and that's what gives rise to a sudden heart attack. And one might have been in a circumstance of apparently perfectly good health until this plaque ruptures. Yes?
Does the same process occur in major and minor arteries?
I'll tell you let's see the next slide. So, this process is called atherosclerosis, and the atherosclerosis affects the intima of large and medium-sized arteries, not smaller vessels. Okay? So the coronary arteries are among the smaller of these medium-sized arteries. But this process involves the blood vessels that go to your head, the blood vessels that supply your heart, the coronary arteries, and your aorta, your major blood vessel that carries blood down to your limbs. And the process doesn't happen throughout the artery. There are sites of predilection for this process to take place. And the sites of predilection relate to the blood flow. And let me give you an analogy. If you think of a river that has a bend in it, the deposit of sand on the banks of the river is not equivalent on either side of that bend. And that's the same thing. When you have a branch point or a bend in the artery, the deposit of these plaques is influenced by the blood flow, and it deposits on one side of the artery. That's why, if we go back for a moment, you see that the depiction of this plaque is on one side of the artery, not throughout the whole artery. Yes?
Where do bacterial superinfections, there's a suggestion that increased periodontal disease increases atherosclerosis. Where does that play in the cascade, in the inflammatory cascade?
Hold on for a minute, okay? Okay, so the effects of this process of the ultimate effects of the process of atherosclerosis are manifest as a coronary heart disease with a myocardial infarction, a heart attack, with stroke, or peripheral vascular disease, the blood vessels that supply your limbs, your legs, your arms, but particularly your legs. So you can have a blockage in the major artery that supplies your legs, and that can give you problems with the health of your legs. Now, one of the things that I need to emphasize that's very important, especially in preventing heart disease, is the discordance between the actual mortality rate and the development of these raised lesions or plaques. Now, this is a plot with age of the development of raised lesions in people, and you see that the plaque begins to be laid down around the age of 20 or thereabouts in most of us, and grows progressively. And it's only when it grows to a substantial size that it begins to give rise to clinical symptoms. So most of us have plaques that are in our blood vessels but are not causing any problem. It's only when they either grow to a certain size or they rupture that they cause a problem. So you see the mortality rate does not parallel the growth of these plaques. And I mention this because it's very important to realize that the treatment and handling of these risk factors, it's important long before you get clinical heart disease. Now we're going to talk about LDL and HDL, and who knows what LDL is? What does it stand for? Low density lipoprotein, okay? Low density lipoprotein. Now let me tell you that all lipoproteins are based on the model that is depicted in this picture here. This is a protein on the surface of this. You can imagine that this is a golf ball. The protein and fats called phospholipids sit on the surface, and all of the cholesterol, or the vast majority of the cholesterol, is buried in the core of the lipoprotein. It's in the center. It's in the core of the golf ball, if you will. Okay? Now, low-density lipoprotein is one of many lipoproteins. They all are structured in the same general way. They all have the surface made up of protein and certain kinds of lipids, and the cholesterol and triglycerides all in the core. It's all in the center of the golf ball. And these lipoproteins are of different sizes. So the lipoproteins that develop from digesting your food, coming into your bloodstream, those are normally very big lipoproteins. And they get progressively reduced in size by the removal of some of the lipid. The low-density lipoproteins are in this size range, and the high-density lipoproteins are still smaller. Why do we refer to these things as low-density lipoprotein or high-density lipoprotein? Anybody got any suggestion? Yes.
The ratio of fat to protein.
And what does that do with respect to the density? It's right.
The more fat, the lower the density.
The more fat, the lower the density. And we take advantage, exactly right. And we take advantage of that property of the lipoproteins to separate them one from the other. So we put them in a tube of different densities, and we allow them to centrifuge, and those that have a density less than the density of the solution that's in the tube will float to the top. We can isolate them. And we can do this progressively with increasing density and isolate these lipoproteins at the top of the tube. So it's very easy to isolate these big lipoproteins because they've got a lot of fat in them. It's not quite so easy, but relatively easy to isolate the low-density lipoproteins. And you need to raise the density substantially in order to isolate the high-density lipoprotein. Okay, so how does this lipoprotein system work? There are two systems, basically. There's an exogenous system and an endogenous system. What I mean by exogenous is the system that comes from the dietary fat. Okay? And the endogenous system is the system that comes from fat that's made within the liver, mostly. So when the fat comes from the diet, it's packaged in these very large particles, and they flow through the bloodstream, and they are acted upon by proteins that we call enzymes that break down the lipid that's inside of them. So they get smaller and smaller and smaller as more of the lipid is taken up. And ultimately, the residue, which we call a remnant, gets taken up by the liver, and it deposits its cholesterol and triglyceride in the liver. And then the liver uses this lipid, either uses the lipid that came from the diet or uses lipid that it makes itself to generate another big particle, not as big as that one, but another big particle, which we call very low density lipoprotein. So it's rich in lipid, it's rich in fat, floats easily, and it's bigger than low density lipoprotein. It's bigger than LDL. And in fact, that's where LDL comes from. LDL is not made by any organ of the body. LDL is a derivative. It's derived from these big particles that are made by the liver. And these big particles made by the liver are digested as they pass through the bloodstream till they get smaller and smaller and smaller, and they ultimately arrive at the size of low-density lipoprotein. Now, all of these lipoproteins have triglyceride in them, mostly. Little cholesterol, but mostly triglyceride. The core of low-density lipoprotein is essentially all cholesterol. All the triglyceride's gone. It's been digested away. And what's left here is mostly cholesterol. And that's why LDL is such a risk factor, because it carries as its target a large amount of cholesterol. Now, the way that this low-density lipoprotein is handled is twofold. One, you can see that it's can be used and can distribute its load to tissues like muscle and adipose and fat and so forth. But it can also distribute its load back to the liver, where the cholesterol can be taken up by the liver and it can be excreted. Anybody know how the cholesterol that gets into the liver is excreted? Bile, correct. It's excreted into the bile. And ultimately the bile goes into the gut and it's excreted in the feces, or some of it is. Some of it's reabsorbed, but a lot of it's excreted in the feces. But the point that I want you to appreciate here is that this low-density lipoprotein that's taken up by the liver and by these tissues requires to see a cell surface, a surface molecule, which we call the low-density lipoprotein receptor. It's a specific molecule on the surface of the liver cells that recognizes low-density lipoprotein and allows it to come into the liver cells. Okay? And for the most part, low-density lipoprotein, LDL, will not enter the liver except through this receptor. It's not totally true, but about 2/3 of the low-density lipoprotein that circulates in the plasma is taken up through this low-density lipoprotein receptor that I'm going to talk to you more about in a moment to get into the liver cell. Now, I just want to go back. Somebody asked me about the question of infection and so forth. I want to go back and tell you a little bit more about this process of atherosclerosis. I told you that the process of atherosclerosis, this is a diagrammatic representation of the intima, okay? It's enlarged here. It's a diagrammatic representation. Here's the endothelium, and the LDL, or low-density lipoprotein, comes through the endothelium into the intima. And if there's a lot of LDL, a lot of it comes into the intima. And in the intima, it undergoes certain changes. These changes involve mostly oxidation. So oxygen gets added to the low-density lipoprotein. And it changes its configuration so that it's no longer seen by this molecule I told you about before, the low-density lipoprotein receptor. It's now seen by other receptors that recognize this modified lipoprotein. And this is important to appreciate because in those circumstances, you can have a total absence of low-density lipoprotein, which I'll tell you about in a moment, but still the cells in the artery wall become loaded with fat. And they become loaded with fat because of these other receptors that recognize the modified low-density lipoprotein. Okay? So the fat gets taken up. The cells that enter the intima were originally called monocytes in the blood, and when they come into the intima, we call them macrophages. And we call them macrophages because they like to swallow up particulate material, including low-density lipoprotein. They are phagocytes. And ultimately, they'll take up enough low-density lipoprotein and store the fat in there to look like this. This is what we call a foam cell. And each one of these droplets is full of cholesterol. Okay? Now, these cells are not quiescent. They're very active. They secrete all kinds of things, including the secretion of signaling or mediator molecules that we call cytokines. They are cell products that have an effect on cells around them. And so this elicits a much more profound inflammation, and instead of having only monocytes, we get other cells from the blood called T cells, which themselves produce more of these mediator cytokines. Doesn't matter what they are for the moment, but these cytokines act on the media, and they ask the media to send some of these smooth muscle cells that make up the media into the intima, and this forms then the fibrous cap. These smooth muscle cells form a layer of fibrous tissue that forms the cap of the lesion. And what you want when you have a lesion is you want to have a thick fibrous cap so that it doesn't rupture easily. Okay? It's only when you have a thin fibrous cap and that can be acted upon by things that break down the fibrous cap that causes it to open up and form a clot because of, yes?
Yeah, I was wondering, a couple of weeks ago I saw an article that said that maybe they might have to restrict people who have certain varieties of heart trouble, that it's bad to intake caffeine, because it seems to me they said the caffeine killed something. I don't know whether it was the HDL or something, but it killed something that was a correlate itself of heart disease problem, and that it might have less effect than what it killed, bad effect than what it killed.
I'm not aware, I didn't read that article. Caffeine, a large amount of caffeine can affect the caliber of the blood vessels, the size of the blood vessels. But I don't know that caffeine has a major effect on LDL or HDL.
I can't remember that it was HDL or
Yeah.
LDL, but it was one of the things that was.
And it also stimulates, I mean, caffeine obviously, you all know this, stimulates your heart rate. You increase your heart rate when you take a lot of caffeine. And the more rapid is your heart rate, the more disturbed is the flow of blood around the heart, which leads to deposition of both lipoproteins and cells. These are the cells that come from inflammation. Okay, so if you have any site of inflammation, like periodontal disease, as you talk, you tend to get a low-grade inflammation throughout the body, and that low-grade inflammation facilitates the development of this lesion. Okay. Okay, so now I want to go back to low-density lipoprotein. If you looked at the population, you looked at this whole room, and we asked what's the level of low-density lipoprotein of all of the people in this room, and maybe more, this would, you'd be able to plot a distribution of low-density lipoprotein that looks something like this. And you'll notice on this plot that the distribution is a little uneven for those who have heart disease, okay? those who have heart disease tend to have higher levels. Not surprising to you. They tend to have higher levels of low-density lipoprotein, as you see from the checked mark. Now, one of the things that we do these days with genetics, everybody's very much into genetics, one of the things we do with genetics is look at the outliers in this distribution. So we look at the people at this end of the distribution, and we look at the people at this end of the distribution. Not because that's going to tell us why somebody in this region gets a heart attack, but the study of these patients is extremely informative. It tells us how these processes work, how they give rise to heart attacks, how the low-density lipoprotein comes to be as high as it is in these patients or as low as it is in these patients. And that's what I'm going to tell you about now. So if you take the extreme of that distribution on the high end, you have a condition, most of the patients in that distribution will have a disease called familial hypercholesterolemia. That is, they have high blood cholesterol that is inherited within their families. Okay? And you can look here, for example, let's just look at the total.
Measured without statins? This
is without statins. I'll tell you just now that statins don't work on these patients, but that's a separate issue. We'll come back to that. No. So here's the total cholesterol, okay? And the people at the extreme end of this distribution, the people who have 2 copies of the abnormal gene that gives rise to this disease, have very high serum cholesterols. For their total cholesterol may be 600 or 700 milligrams per deciliter, okay? And if you look at where this cholesterol is distributed, almost all of it is in the low-density lipoprotein range. There's not much difference in these primary particles, the very low-density lipoprotein. Not much difference in the high-density lipoprotein. It's all in the low-density lipoprotein. So I need to back off and try and get you to appreciate how this molecule that takes up the low-density lipoprotein, the one that I talked about before, the low-density lipoprotein receptor, how this works and how it works to regulate what we do with our cholesterol. So here's some low-density lipoprotein. It's loaded with cholesterol. It's recognized by its receptor, and the whole particle is then taken up into the cell. And ultimately it gets broken down and the cholesterol is liberated from that particle. Okay? The cholesterol is liberated from the particle. Now, if some of this cholesterol is used for cell growth, I should have emphasized, and let me emphasize it now, that cholesterol is an essential component of cells. We need cholesterol for our cells to grow. We need cholesterol to make some of the hormones that we make. It's an essential ingredient of our bodies. The whole trick is not to have too much and not to have too little. And so, whenever you're faced with a situation like that, you have a very detailed regulatory mechanism to try and keep everything in order, to keep the cholesterol level in order. So you don't want it to get too high and you don't want it to get too low if you're normal. So now, if we're bringing cholesterol into the cell through this low-density lipoprotein, the cholesterol is deposited here. It can go for cell growth or for other purposes. It can be excreted into the bile. Or it can be stored in the cell in the form of those big droplets that we talked about in the atherosclerotic plaque. But also, if you have a lot of it coming into the cell, what happens is that the cell senses that it has an oversupply of cholesterol, and I don't have the time, and I'm not sure that you have the interest to go into the details of how that happens. I can just tell you that this process here, that's depicted on this slide, won 2 gentlemen the Nobel Prize about 20 years ago. And they worked out how developing an oversupply of cholesterol regulated the inflow and production of cholesterol in the cell. So if you have an oversupply of cholesterol, it inhibits new cholesterol formation, the new synthesis of cholesterol. If you have an oversupply of cholesterol, it inhibits the formation of these receptors so that you don't take more LDL into your cell. So there are two things that get regulated: the amount of cholesterol that you make and the amount of cholesterol that you take into your cell. Both of those are regulated if the cell senses that that it's getting too much cholesterol. That's the normal situation. Okay? Now, there are three sources of cholesterol in our bodies. We can get cholesterol in our diet, we can get cholesterol by making it in our cells, or we can get cholesterol by taking up low-density lipoprotein from the blood into the cells. Those are the three sources. This is probably the least important from the point of view of heart disease. Not to say it's unimportant, but of these two processes, it's probably the least important. So if you take extra cholesterol in your diet, you will raise your plasma cholesterol, and some of it may go into the arteries. But it's much worse to have too much synthesis or too little uptake. Okay? So now how does this low-density lipoprotein receptor regulate the amount of low-density lipoprotein in the plasma? You notice I told you the people who have familial hypercholesterolemia have this very high level of low-density lipoprotein in their plasmas. How does that very high level of low-density lipoprotein happen? Well, let's just look at the normal situation first. The liver makes the precursor of low-density lipoprotein. I told you earlier it's very low-density lipoprotein. That's metabolized, and it gets converted into a smaller lipoprotein that's got a lot of cholesterol in it. And then most of that is recycled back into the liver. Most of that is recycled back into the liver, LDL and its precursor. And what is responsible for that recycling back into the liver is this low-density lipoprotein receptor. Okay? So what happens if you don't have any low-density lipoprotein receptor? It's lacking on the surface of these liver cells. All that happens is this stuff can't be taken up, and it accumulates in the plasma. So the reason why these low-density lipoprotein levels are so high in the patients with familial hypercholesterolemia is, in fact, that they don't have this receptor. They are lacking this receptor. And so whenever they make very low-density lipoprotein, most of it stays in the plasma ultimately as low-density lipoprotein because it can't recycle like it normally does back into the liver. Yes?
Are they lacking the receptor or are the receptors faulty?
Either can be the case. So if they're lacking the receptor, the level goes much higher. If the receptor is partially functional and faulty, the levels will not be quite so high, but they will still be elevated.
And will that be a recessive condition? Do you need to get, or is it both genes are expressed?
It's not recessive. This is a dominantly inherited disease because, as you know, the difference between recessive inheritance and dominant inheritance is you need two genes to be abnormal in recessive inheritance for any manifestation. In dominant inheritance, one gene is sufficient to create abnormality. It's worse with two genes, but one gene.
Is it codominant?
It's codominant.
Okay.
Yes.
If an individual has a liver disease
Yes.
due to genetics or accidents or, say, alcohol abuse,
Yes.
does that increase the chance for artery disease?
It may do. It's much more complicated than it seems. It may do. And it may not necessarily. It depends on, you see, if you have fewer functioning liver cells, you'll make less of the precursor for LDL, okay? As well as not being able perhaps to take it up. Yes?
Is this mutation more common in certain ethnic
Not particularly. I think it tends to be a little more common in Jews, but it's fairly widely distributed.
I have maybe you can clarify this question for me. It's a very dumb question. What if
All good questions seem dumb the first time they ask.
Well, if you apply to an insurance company,
Yes.
then say, if you have high cholesterol,
Yes.
does that mean you have heart disease? What is the terminology for deciding if you have heart disease?
There's a difference between having atherosclerosis, okay, which is plaque deposition that I showed you earlier, and having overt heart disease. So if you have a high cholesterol, you don't necessarily have clinical or overt heart disease, but you may have plaque in your arteries.
Okay.
That puts you at risk of ultimately getting these bad things. Okay? You may not get them. That's true. You may be lucky. Yes.
Does diabetes relate to this? Why does diabetes cause heart disease?
Well, diabetes is one of the most complicated diseases from the point of view of this whole story. There are a number of ways in which diabetes can promote or increase the frequency of heart disease. First of all, as you know, there are two kinds of diabetes. There's type 1 diabetes and type 2 diabetes, and the type 2 diabetes is usually with people who are overweight. When they are overweight, they tend to have what we call insulin resistance. Do you know what that is? That means that you need more insulin in your blood in order to handle the fat, the carbohydrate that you take in, okay? So some of us only need a little bit of insulin to handle the glucose that we take in our diets. Some of us need a lot of insulin to handle it. You won't be diabetic, but you'll have a high level of insulin in order to handle the carbohydrate. What happens when that high level of insulin actually works on the liver to increase the production of very low density lipoprotein. Even though the patient is not yet diabetic, there's an increased production of this very low density lipoprotein, ultimately giving rise to LDL. Okay? In addition to that, most diabetics have low HDL, which we'll come to in a little while. So for both of those reasons, the diabetes might promote heart disease. Any others? It's okay if I don't finish this. I'd much rather answer your questions. Okay. Now, I don't expect you to even grasp all of this. I am showing you this only for one reason, and that is to show you where the statins work. Okay? This is the biochemical pathway for making cholesterol. And you don't need to pay any attention to the names that are on here, except one, and that's this one, HMG-CoA reductase. This is an enzyme that is involved in the early stages of cholesterol formation, and it is the target of statin. Statin inhibits this enzyme. So it inhibits cholesterol biosynthesis. It inhibits the formation of new cholesterol. Okay? Forget about all the rest of it. Just that one. So now let's just simplify that a little. Normally, this is a normal liver cell. The cholesterol can come from cholesterol formation, new cholesterol formation. It can come from taking up LDL through the receptor, okay? And it develops a certain level of cholesterol in the plasma, and there's a balance between the what's coming in and the new cholesterol synthesis, okay? Now, what happens if we have too much cholesterol in our cells? Supposing for whatever reason we have too much cholesterol in our cells, the excess cholesterol will inhibit cholesterol synthesis, I told you, and it works, that inhibition of cholesterol synthesis works at the same place the statins work, exactly the same place. It regulates exactly the same step that the statins regulate. And it inhibits new cholesterol synthesis. But it also inhibits new receptor synthesis. So, when you store a lot of cholesterol in your cells, admittedly you reduce the amount of new cholesterol that you make, but you also reduce the number of LDL receptors on the surface. 2 there and 1 there, okay? And because of that, you accumulate LDL in the blood. So the accumulation of LDL in the blood is really the indirect consequence of too few LDL receptors, probably due, if you don't have a genetic defect, probably due to the accumulation of too much cholesterol in the cells. What happens with statins? What statin does is it inhibits the new cholesterol formation, just like high cholesterol does. But there's no additional cholesterol coming into the cell, so the cholesterol goes down substantially. And in fact, the reduced cholesterol allows, the cell says to itself, I don't have enough cholesterol because statin has inhibited the new cholesterol synthesis. So it says, I don't have enough cholesterol. So let's make some more LDL receptor so that we can acquire cholesterol from the blood. So now there's more LDL receptor on the surface of the cells, and the LDL is taken up from the bloodstream, and the concentration of LDL in the bloodstream goes down. And that's very good for your arteries. Okay? So statin doesn't work directly on LDL. That's my point. It works by inhibiting cholesterol synthesis, and the regulatory effect of that is to increase the number of LDL receptors that can remove LDL from the plasma, causing it to go down in concentration and exposing your blood vessels to much lower concentrations of cholesterol, of LDL. Okay, is that clear? Yes?
I have a question. Do the statins ever stop working after years and years of taking them?
Not really, because they direct. It's a complex question because they don't ever stop working completely. But what happens, I don't know whether you really want to know this, but what happens when you inhibit cholesterol synthesis like this with statin, the cell makes more enzyme that statin normally inhibits. It adapts to, so it compensates for the fact that you've inhibited that enzyme by making more of it. Okay? So what you should be taking away from this is the fact that cholesterol is such an important component of our cells that we use many, many different devices to regulate how much there is in the cell. Many devices. And that's true throughout of biochemistry and biology. When a component is very important, there are many ways to regulate that component. Nature doesn't rely on a single regulatory mechanism. Yes?
So it seems that the end result of this is to increase the rate at which LDL can be removed from the blood.
Correct.
But wouldn't there be some other mechanism that then uprates the introduction of LDL into the blood, create the LDL?
In order to make very low density lipoprotein, there could potentially be. But in order to make, and in fact, there is an increase in fat synthesis in the liver cell with statins. So there is a tendency to reverse this phenomenon. But what we're doing is we're titrating, we're grading the amount of statin that we need in order to keep the system in a new balance. There are many regulations that are happening all along this route. But the statin, your physician, if you're taking statin, your physician will adjust the dose of the statin to achieve the goal that he or she wishes to achieve with respect to your LDL concentration. But there are all kinds of other things happening inside of your cells, yes. Yeah.
Like any other drug, you frequently talk about with friends in this, and they'll say, well, it's different when you pull it out of the blood pressure out, or the statin, or the HDL down using drugs. If it were, you still don't do as well as natural
absolutely
biology. And is that true? For instance, I have Zetia and the other one. I got a cat of Lipoprotein.
Yes.
And brings it down to about 240 to 138, and I hover at that rather constantly. How, in terms of, are there other factors always operating also that are correlated with it?
I'm not quite sure what other factors you're referring to.
Well, are there other, in other words, are you likely to have other factors correlated with it?
The only known problem with statin treatment is muscle problems. People often get cramps that they may or may not be able to tolerate. We don't fully understand the nature of these cramps. There's some suggestion that it may have something to do with vitamin D deficiency, but that's not proven at this point. We don't understand that, but some people have to stop taking statins because their cramps get so bad. And that's one of the reasons why the pharmaceutical company have introduced alternate medicines for the treatment of hypercholesterolemia, like Zetia, for example, which has a different mechanism of action.
The question is slightly different than that. They're the truth. They basically are saying, they say it on almost any drug anyway. So all these drugs you have to take to keep going don't do as well as naturally and so forth.
Well, I think that's true, but we're not yet clever enough to intervene naturally without drugs. Hopefully we might be able to do that one day, yeah.
The way you describe the actions of statin, to me, implies then you should never suddenly stop it, because then your liver's going to be flooded with cholesterol, and the receptors are going to then drastically decrease, so you're going to have an overshoot getting back to equal normal.
You may, that's very, very well spoken. You don't have to take it forever, but you have to be aware of the fact that you may in fact have an overshoot and maybe adopt alternate strategies like taking Zetia, for example.
Is there any evidence that with the aging of the genome that the activity of these enzymes responsible for things like cholesterol synthesis or receptor synthesis are downregulated as a function of age? Has anyone looked at that? Is it easier to drop?
I'm sure there's work done on it, but I don't think there are any dramatic results related to age effects on these pathways. There are obviously lots of other age-dependent pathways.
Is it easier to drop your cholesterol when you're older versus when you're younger?
That's probably a function of your activity. I mean, if you're young people tend to be much more active than we are, and so that would help to keep your cholesterol and lipids down, all of your fats down. Yeah.
If you ate a very low cholesterol diet, a vegan diet, for instance, would there be any need for a statin?
Would there be any use for statins, you say? It depends on how you respond to that low cholesterol diet. It's true that if you were able to lower your cholesterol sufficiently by eliminating cholesterol from your diet, you may be able to avoid taking statin. I mean, you may be okay. You may be able to avoid taking statin. Not everybody gets high blood cholesterol, so statin isn't necessarily for everybody. But remember that there are these other processes that are going on inside of the cells, like cholesterol synthesis, If you have too little cholesterol, if you have a low level of cholesterol coming from your diet, then your cells tend to make more. So it will depend upon the balance within your own physiology whether you'll be successful or not. Yeah.
Is there any knowledge about how inflammation of the endothelium, vascular endothelium, is affected favorably by statins?
There is. I didn't want to get into this, but that's a whole other area. The statins are thought to have effects that are independent of the cholesterol level. If you really want an answer, let's go back to that. Some of the products that are made along here are used to modify inflammatory, not the cholesterol itself, but the intermediates that are made on this pathway are used to influence inflammatory reactions. Those are things that activate certain components of the inflammatory reaction. So there's some people who suggest that the statins will improve the inflammatory profile because of the effect on these intermediates that's independent of cholesterol. Okay? Yes?
Why is it that the statins don't work with people who have the familial?
Because the way that the statin works, okay, is to increase the production of the low-density lipoprotein receptor. That's the ultimate, I mean, it works on cholesterol synthesis, but the ultimate effect is to increase the production of the receptor. If you can't make any receptor, you can't increase its production, so it's not going to work. Okay?
Then it doesn't work to increase the receptors.
Yes.
Does it do anything? Can it therefore be stopped without the side effects that you talked about before from stopping it?
The fact that it can't increase the number of receptors is independent of what it does to the enzymes that make cholesterol. So they will still increase as an adaptation to the presence of statins. Okay, and you're not likely to get a great deal better. You may even get a little bit worse. Excepting for the point that this gentleman raised before about the effects of statins on other things than cholesterol metabolism. Yes?
Is there any evidence or any research that shows that the use of statins negatively affects memory?
No, the contrary is the case, I think.
What's the effect of exercise?
Well, exercise is a good thing, and it's a good thing because it facilitates the metabolism of fat. And in order to make all these lipoproteins, you have to have fat in your livers to make them. So the more fat you can metabolize by exercise, the better off you are from the point of view of making these additional lipoproteins. Can we go on? Scott, you'll have to tell me when I need to stop, okay?
15 minutes to go.
All right, so I told you that whenever something's vital, there are many ways to regulate it. And we've talked about regulating the low-density lipoprotein receptor by synthesis. But there's also a way of regulating it by degradation, by removing the low-density lipoprotein receptor. And recently, there was a protein, an enzyme discovered that facilitates the degradation of the low-density lipoprotein receptor. And under normal circumstances, whenever you stimulate the production of low-density lipoprotein receptor, like we've talked about, you also stimulate the production of the stuff that degrades the low-density lipoprotein. So it's very complicated. You have to achieve a balance, and the body has the mechanism to achieve as close to a perfect balance as possible. You make additional low-density lipoprotein receptor. You don't want to make too much, so there's a mechanism to remove any excess low-density lipoprotein cholesterol. This only came to light within the last 5 years, and it's a very exciting area of research. I showed you this distribution of low-density lipoprotein cholesterol, okay? And we were talking about those who don't make the receptor having cholesterols at this end of the distribution. There have been mutations found in that enzyme that degrades the low-density lipoprotein. Just imagine, if you degrade the low-density lipoprotein receptor, you're going to remove its capacity to take up LDL, right? But if you have a mutation in that degrading enzyme, what will happen is that more low-density lipoprotein receptor will hang around, and it will take up more LDL, okay? And so the people who have that kind of a mutation will actually have low levels of low-density lipoprotein, okay? And the people who have low levels of low-density lipoprotein have much lower cardiovascular disease because they have lots of one of you was talking about how can we have nature manipulate the system to have lots of low-density lipoprotein receptor to take up LDL. This mutation is such a manipulation. It's better than statins. It's better than statins. It allows the accumulation of low-density lipoprotein receptor because it's not being degraded, and that removes the low-density lipoprotein from the plasma. This is the normal distribution. This is the distribution in the mutant individuals, and it has a major impact on vascular disease. So that gave rise to some questions about why is it that, and these people who have that kind of a mutation have virtually no heart attacks. This is a theoretical plot which shows you the cumulative LDL cholesterol years. So what they did was they took the LDL cholesterol level and they multiplied by your age, okay, to say this is the cumulative effect of LDL cholesterol on your arteries. The level plus the time that the arteries have been subjected to that level. So that's the cumulative level. So people who don't have low-density lipoprotein receptor, they are subject to a very high cumulative level over a relatively short space of time. And this is the incidence of heart attacks, okay? The lowest age at which you get the lowest level at which you get, and the highest level, and this is the mean. And the people who have no low-density lipoprotein receptor get their heart attacks very early, okay, because they're subjected to this high cumulative LDL cholesterol. If you have, this is a dominant gene, if you have one copy normal and one copy abnormal, this is the pattern. Okay? If you're a normal individual, have normal LDL receptor regulation, this is the pattern. Okay, now I want to move on to, for the last 5 minutes or so, I want to move on to HDL. Okay? And I just want to point out to you that the risk of this is called the Framingham risk profile. The Framingham in Massachusetts was a city in which large epidemiological studies were done on normal people. And you see this is the risk of cardiovascular disease, and it goes up with the level of LDL cholesterol, okay? But there's also an interaction with HDL. This is the high HDL, this is the low HDL. If you have a low HDL together with a high LDL, you see that the risk is enormously increased. So at any one LDL level, the risk is related to the HDL level, inversely related to the HDL. So if you have a high LDL, you're better off having a high HDL as well. Okay? The worst situation is to have a high LDL with a low HDL. That's what this plot shows. Now, what does HDL do? Well, one of the things that HDL does is it harvests this extra cholesterol that's in the tissues for people who've got too much cholesterol in their bodies. And among the tissues that we're most interested in, obviously, are the blood vessel walls. So HDL harvests the cholesterol from the blood vessel walls, carries it in the blood back to the liver for disposal. Okay, so that's one of the major things that HDL does. But it's not the only thing that HDL does. HDL, unfortunately, is extremely complex. It has many different functions. That, what I just told you, is one of the things which we call reverse cholesterol transport. That is, transport of cholesterol from the peripheral tissues back to the liver for excretion. But it also has antioxidant effects. It also has anti-inflammatory effects. It also has anti-clotting effects. It also has effects to promote the caliber of the blood vessels, allowing them to expand through effects on the enzymes that make nitric oxide. So HDL has many effects, and when we think about the effects of HDL on cardiovascular disease, it's not possible at the moment to focus exclusively on one action on the part of HDL. Unfortunately, LDL's reasonably simple because it's all more or less the same. All of these red things are cholesterol inside the LDL particle, by the way. HDL comes in at least two forms. It comes as a bigger HDL, HDL2, or a smaller HDL, HDL3. And someone was talking about gender effects earlier. Women tend to have higher levels of HDL2 than men do. People who exercise have higher levels of HDL2 than HDL3. And this just shows you what effect that is. If you compare coronary heart disease-free subjects and coronary heart disease cases, the major difference is in the HDL2, not the HDL3. So there's an inverse relationship between the concentration of HDL2 and the incidence of coronary heart disease. Yes?
From what you said here just now, it looks as though, other things being equal, it's in your interest almost every time, most people, to have a higher level of HDL than what you might otherwise, what might be natural.
Yes.
That being given then, is it not possible or prudent that someone should market, or maybe you can buy it, you could buy what are called an HDL supplement? Take it like fish oil supplements or vitamin supplements?
Unfortunately, I'm not going to get time to do this, but that's where I was getting to. Okay.
I see.
But the therapy for HDL is still very primitive.
Oh, I see.
Okay. But people are thinking along the lines that you suggest.
All right. Well, it just sort of
Right.
With women past menopause, does that change?
It tends to change somewhat, yes. This is probably at least partly hormonally regulated, yes. Yes.
So the drugs they're making now for this HDL, they would go on the 3 or the 2? Or
It's not clear at the moment. Not clear at the moment. It does matter. That's what this chart tells you, is that at least epidemiologically, it does matter. It matters. It seems to matter. You're better off having more HDL2 than HDL3.
To get back to diabetes and how it affects the story, because it really must be very interactive.
Very what?
Interactive.
Yeah, it is. One of the, I told you, let's go back. I told you that one of the functions of HDL is to remove cholesterol from the tissues, okay? This involves a complex series of biochemical reactions, which we obviously don't have time to go into. But diabetes affects the capacity to extract the cholesterol from the peripheral tissues. And that's actually a thing that we're doing some work on at the moment. Yes?
I've heard that HDL is harder to change
Yes,
medication.
you're correct.
Because it tends to be inherited.
It's not clear whether it's inherited.
Because it has so many different...
The problem with HDL is that the regulation of HDL levels is so complex, involves so many factors, and that we haven't yet figured out a good way in order to regulate this stuff. It's much more difficult to treat. As the gentleman over there said, the obvious thing is to give HDL and raise it, but that's not very simple to do.
Well, to what extent does high HDL compensate for high LDL?
This is what this chart was addressing, right? So the higher your HDL, the better off you are at any given LDL level. So if you have a higher LDL level, you need to have a higher HDL level to counteract that.
I guess we're getting to your last call here.
Okay, I just want to tell you one of the pieces of work that we're doing. This is, never mind how we do this. We plot HDL2 and HDL3. If you look at a mouse, the mouse only has one kind of HDL. But you can take the protein from the human and give it to a mouse, and you can make two kinds of HDL. And the protein that does that is called apoprotein A1. And you don't have to worry about this is a structural diagram of what apoprotein A1 does. And you notice that it has, these are helices. These are helices. This is a helix bundle. And there's a transition zone over here which links this helix bundle to this portion of the molecule. We are making in our lab mutations of this region of the molecule in order to find a protein that will prefer to make HDL2 over HDL3. That's what we're actively engaged in at the moment. Okay?
How well is it going?
Well, we're right. I'll be able to tell you in about 4 weeks' time.
Now, when you get a report from a blood sample, it normally doesn't have HDL2 and 3.
No, it doesn't. This is only done.
Difficult to do?
Those, yeah, they're much more difficult to do. Yeah. You don't get that information on a normal blood analysis because this requires separation by putting the stuff into a centrifuge, like I told you earlier. Right?